So the ultrasound has this red tip on it, and it goes into the computer or into the monitor, and it can only go in one way. And I'll demonstrate that. But the one that picks up the contractions, the Toco, it's brown, or it's a different color. So they're color coded. You're not going to be able to put them in wrong or break anything or anything like that. So the ultrasound, it uses ultrasound technology, and it kind of looks at the valves of the fetal heart opening and closing and translates that into a number for us and beats per minute, so that we know what the heart rate is. So it's not direct. It's not at all like an EKG. So if you know anything about EKGs, forget it when you're talking about a monitor. Then this is a contraction monitor, and it's got a little pressure transducer on here. And so we don't add anything to it. That's one way to remember. Like if it's got a bump, you don't need to put lubrication on it. If it's smooth, you do. So this is going to pick up our contractions, and the way that we're going to figure out where the best place to put this is we're going to palpate her abdomen when she's having a contraction. And you just press and release, use the pads of your fingers, press and release, press and release. And where you can feel the contraction the most intensely is where you want to put this, because that's where, you know, if you're over small parts over here, it may not trace very well, but you just want to feel it during the contraction. And that's how you're going to know where you're going to put that one. And this one actually has a little button still on it, and our strips or our belts have little buttonholes in them. And it just goes on like that. Very pretty. And then these get plugged into the machine. So it's just these two belts that are on the outside. If she needs to get up to the bathroom, we can, and if she's ambulatory, if there's no reason she shouldn't be getting up by herself, we can show her just how to unplug these from the monitor. She can put them around her neck, walk to the bathroom, come back, and plug herself back in. It's that easy. And it's that easy for you too. With one caveat though, sometimes, you know, as the baby is descending, getting closer to delivery, we move the ultrasound down as the baby gets closer. But if we're tracing the contractions and they're tracing well, a lot of times we don't even think about taking this off or moving it. And if we're doing this little trick of leaving the belts on so she can get herself up, or if she has an epidural and she's not getting up, you do need to be aware that you can have some pressure sores right here, because you've got this little transducer right here. And if she has a 12-hour labor and we never move this, I have seen sometimes when at delivery we take the monitors off and we've actually got some skin breakdown here. So you need to remember that. You need to look under here every now and then, massage the skin, and move it, even if you just move it a little smidge, to prevent skin breakdown. And if she has a labor epidural, she's not going to feel, well, and even if she doesn't, if they're having contractions, they're not going to alert you. They're not going to say, oh, this monitor is bothering me, because they're feeling their contractions. Or if they have an epidural, then they won't feel that. So it's important for us to check. So that's external monitor. And I'll just tell you real briefly that we do have internal monitors we can use if we need to. And they are invasive. They do increase the risk of infection. So we only use them when we really need them. And when would that be? That might be a patient that we're inducing and we really need to quantify the strength of the contractions. With the belt that's on the outside, that doesn't measure strength. You have to palpate the abdomen to determine, and ask the mom and look at her demeanor to determine the strength of the contractions. But sometimes it can look like they're having really good contractions, but they're not progressing. Their labor's not progressing. So we might want to put an internal pressure catheter in, which is this thing. And again, you'll see all kinds of different ones, different brands and all of that. But this has a pressure transducer on the end, and this goes in through the cervix, in the vagina through the cervix, and then it's advanced through this little guard, and it goes up inside the uterus between the uterine wall and the fetus, and it actually measures the pressure inside the uterus in millimeters of mercury. So we really know how strong those contractions are. And then we have, this is a fetal scalp electrode, an IFSE. And this has a little, you'll be able to play with these, except they're not sterile and they are sharp, so be careful. But this has a little screw in it, and what we do with this, we do a vaginal exam. She's got to be dilated a little bit, a couple centimeters at least, and membranes have to be ruptured in order for us to use the internals. So we can, if she's in good labor, if she's in labor and we need to, we can rupture her membranes so that we can put these in. But you wouldn't use this, if a triage patient came in and she wasn't in labor, you would not use this because you wouldn't want to break her water. That starts a 24-hour countdown when we want to have people deliver within 24 hours of their water breaking to minimize the risk of infection. So you would only use this on a laboring patient. So this has a guard on it too. This one doesn't, but the real one's not real. This is a real one, but it's just lost some of its parts. But we do a vaginal exam, and then we feel the top of the baby's head, and I can bring fetus back out here. So if baby's in like this, we'll do a vaginal exam, feel the cervix, and then we'll feel the top of the baby's head and decide where we want to put this. And then we just go in with our guide, and we give it a little quarter turn twist, and this needle goes just under the skin of the baby's scalp. And this detects electrical activity. So this is more accurate than the ultrasound. So if we have somebody who's difficult to monitor, maybe mom's really fluffy, or like I said, the best place to hear the heart tones is over the baby's back or shoulder. Well, if we've got a little ornery baby in this position, this occiput posterior position, sometimes it's very difficult to monitor the heartbeat. So we might want to do that. But like I said, we're only going to do that if it's indicated because of the risk of infection. And, theoretically, you have to be trained to do this. Of course, this isn't a new staff nurse doesn't put in internals. You have to have extra training and get certified in it. But, theoretically, it's possible that you could go through the uterine wall with this thing if you weren't doing it right. And we want to avoid the fontanelles, or little soft spots. We don't want to put the scalp electrode there. So you have to be skilled enough to figure out where the baby's head is. And then what we do, once those are in, we can take the monitor belts off of the outside, and they just plug in, the internals plug into the same kind of cord. We unplug it from the machine, and then we plug this in, and it's the same for the heart rate, it's red, and for the internal pressure catheter, it's brown, or whatever the machine is. But they just have a little different end on them. And I don't know, oh, here. So here's the one for the internal pressure catheter. Same color, it fits in the same place, but the end of it, the pressure catheter just plugs into this. And this is all done sterilely. So it just plugs into that, we plug it into the machine, and we're getting the actual pressure inside the uterus. And while I'm here, I will just point out that this looks like kind of like a IV connection, right? So if I pull this cap off, it's just like what we would hook an IV up to, and that's what it is, and that's what it's for. We'll talk about some of the complications during labor, but sometimes we need to put some fluid back in if our membranes are ruptured and then the cord's being compressed. Sometimes we put some fluid in, and that's called an amnio infusion. And so that's where that goes in, and then that fluid goes into the uterus to help cushion the cord. But we won't go into those details right now. So that's our internal and external monitors. Leopold maneuver. You need to know the various positions, occiput anterior, posterior. Look in your book because there are a lot of them. We can have a shoulder presentation. We can have the baby like this, transverse or breech, or we can have a foot down. So there's a lot of different positions the baby can be in, so you need to be familiar with that too. So Leopold maneuver, fetal monitoring, you need to know the normals for the fetal heart rate so that we know if we have a healthy baby or not. So that's mama and the monitor, and then we'll look at the fetal monitor and look at some actual monitor strips at our next station.